Nicotine is often described as a stimulant, something like caffeine, but stronger. The assumption, especially in recent years, has been that if you remove the combustion, you've removed the harm. What's left is just the drug itself, a relatively clean pharmacological tool. But nicotine isn't clean, and it isn't just a stimulant. It's a molecule that has been chemically re-engineered over 6 decades to deliver faster, penetrate deeper, and bypass every natural signal your body uses to tell you to stop. And unlike almost every other addictive substance, the more you use it, the more receptors your brain builds to accommodate it. You're not developing tolerance, you're developing dependence at the structural level. In 1964, researchers at Philip Morris discovered that adding ammonia-based compounds to tobacco changed nicotine from a salt to a freebase. Freebase nicotine crosses the blood-brain barrier within seconds, creating a pharmacokinetic profile closer to intravenous cocaine than to oral caffeine. This Marlboro secret allowed nicotine to spike in the brain almost instantly. Then, in the mid-2000s, companies like Juul used benzoic acid to create nicotine salts. This reformulation solved a specific problem: how to deliver extremely high concentrations without triggering throat irritation. Early freebase e-cigarettes were capped at around 12 milligrams per milliliter because anything higher was physically unpleasant. Nicotine salts removed that ceiling entirely. A single pod could now deliver as much nicotine as an entire pack of cigarettes, inhaled over minutes, with no harshness to signal overexposure. The irritation wasn't removed to make the experience safer, it was removed to make higher doses tolerable. To understand why nicotine is so uniquely addictive, you need to understand what happens to your brain when you use it repeatedly. And the mechanism is counterintuitive. Nicotine works by binding to nicotinic acetylcholine receptors, specifically a subtype called the alpha-4 beta-2 receptor found in high density throughout the brain's reward circuitry. These receptors are normally activated by acetylcholine, a neurotransmitter involved in attention, learning, and arousal. But nicotine has a higher affinity for these receptors than acetylcholine does. It hijacks them. When nicotine binds to the receptor, it opens a channel that allows sodium and calcium ions to flood into the neuron, triggering a cascade of activity that ultimately leads to the release of dopamine in the nucleus accumbens, the brain's primary reward hub. That's the hit. That's the reinforcement. But here's where nicotine diverges from almost every other drug. With most addictive substances, alcohol, opioids, stimulants, the brain responds to chronic exposure by down-regulating receptors. It reduces the number of binding sites to try to restore balance. Nicotine does the opposite. Chronic nicotine exposure causes a marked increase in receptor density. This is called the upregulation paradox. The mechanism is elegant and punishing. Nicotine doesn't just activate the receptor, it desensitizes it. After repeated exposure, a significant portion of your receptors become locked in an inactive state. They're physically present, but functionally offline. Your brain detects this as a deficit and responds by synthesizing more receptors and transporting them to the cell surface. Now you have more receptors than you started with, but a large fraction of them are desensitized, so you need more nicotine just to activate the receptors that are still functional. And when the nicotine wears off, you're left with a surplus of unoccupied, hypersensitive receptors and a deficit in baseline cholinergic signaling. This is why nicotine withdrawal doesn't feel like coming down from a high. It feels like your brain isn't working, because structurally it isn't. You've built a system that requires nicotine to function normally. The addiction isn't psychological anymore. It's architectural. Nicotine's addictive power isn't just about dopamine. It's about when and how the dopamine gets released. The ventral tegmental area is the origin point of the brain's dopamine pathways. Dopamine neurons here are regulated by 2 opposing forces: glutamate, which excites them, and GABA, which inhibits them. Think of glutamate as the gas pedal and GABA as the brake. Nicotine acts on receptors on both glutamatergic and GABAergic neurons. It stimulates the release of both neurotransmitters simultaneously. At first, this seems balanced. More gas, more brake. But the receptors on GABAergic neurons desensitize much faster than those on glutamatergic neurons. What happens next is a state called disinhibition. The inhibitory brake fades while the excitatory drive remains active. The result is a prolonged, massive release of dopamine, not a short burst, but a sustained flood. This is why nicotine doesn't feel like a recreational high. It feels like focus, like clarity, like you've unlocked a better version of your baseline cognition. The brain interprets the dopamine surge not as pleasure, but as salience, a signal that something important is happening, something worth repeating. And because the timing is controlled by receptor desensitization rates rather than dose alone, the brain can't easily habituate to it. The mechanism is self-perpetuating. Every time you dose, you're training the reward system to expect that surge, and every time you don't dose, the system crashes below baseline. When nicotine is withdrawn, glutamate transmission in the prefrontal cortex and limbic regions drops sharply. This is driven in part by the downregulation of metabotropic glutamate receptors, which normally regulate excitatory signaling. The result is a neurochemical crash characterized by irritability, anhedonia, the inability to feel pleasure, anxiety, and profound dysphoria. This isn't craving. This is the brain entering a state of functional deficit. The adolescent brain is uniquely vulnerable to nicotine, and the reason has to do with timing. During adolescence, the brain undergoes a massive reorganization. The limbic system, the emotional and reward processing centers, matures early during puberty, but the prefrontal cortex, which provides executive control, impulse regulation, and long-term planning, doesn't fully mature until the mid-20s. This creates a maturation lag where the drive system is fully online, but the braking system is still under construction. Nicotine exposure during this window doesn't just accelerate addiction, it alters the developmental trajectory of the brain itself. One of the most significant changes identified in longitudinal studies is the downregulation of metabotropic glutamate receptor 2, MGLUR2, in the prefrontal cortex. During active nicotine use, the brain upregulates MGLUR2 to suppress the excessive glutamate release caused by chronic stimulation. But when the adolescent stops using nicotine, MGLUR2 levels don't return to baseline. They crash to significantly below normal. This deficit has functional consequences. The synapses in the prefrontal cortex lose their ability to undergo short-term depression, a process critical for filtering and prioritizing information. The result is chronic attention deficits, measurable, persistent impairments in focus and cognitive control that last long after the person has quit. Human studies confirm this. Individuals who began smoking or vaping during adolescence show attention deficits that persist into adulthood, even years after cessation. The brain doesn't reset. The developmental injury is permanent. There's also evidence of cross-sensitization. Adolescent nicotine exposure primes the brain to respond more strongly to other addictive substances, cocaine, alcohol, opioids. The reward system has been structurally altered in a way that makes it more susceptible to reinforcement from other drugs. And it's not just the brain. Longitudinal data from cohorts who smoked persistently from childhood through young adulthood show a 33% to 52% greater chance of premature structural cardiac injury by age 24. The heart, like the brain, is undergoing critical development during adolescence. Nicotine doesn't just affect behavior, it affects morphology. Nicotine directly induces insulin resistance by overactivating the mTOR pathway, which phosphorylates insulin receptor substrate 1. This muffles the insulin signal. Cells stop responding even when insulin is abundant. The pancreas compensates by producing more insulin until beta cells exhaust and die, leading to type 2 diabetes. Nicotine also promotes visceral fat accumulation. You can appear lean while developing the metabolic profile of obesity. In the heart, nicotine stimulates the TGF-beta pathway, increasing collagen production. Studies of bypass surgery patients found nicotine exposure was the only variable correlated with interstitial fibrosis in the atria. This scar tissue disrupts electrical conduction, creating a substrate for arrhythmias and diastolic dysfunction. Unlike elevated heart rate or blood pressure, which normalize after cessation, fibrosis is permanent. The heart's architecture has been altered. Nicotine provides real cognitive benefits for people with ADHD or schizophrenia, but only temporarily. In ADHD, nicotine improves focus by stimulating receptors in the prefrontal cortex. but chronic use leads to receptor upregulation. The brain requires nicotine to achieve what used to be baseline attention. Between doses, symptoms worsen. In schizophrenia, patients show deficits in P50 auditory gating, the ability to filter sensory information. Nicotine temporarily restores this function, which explains smoking rates of up to 80% in this population. But alpha-7 receptors desensitize within seconds, requiring constant redosing. The drug works, but it traps users in a almighty cycle where the baseline state becomes progressively worse. Between 2020 and 2024, daily nicotine vaping among youth vapers nearly doubled from 15% to 29%. Unsuccessful quit attempts rose from 28% to 53%. More than half of daily youth vapers tried to quit and failed. The driver is dose. Median nicotine concentration rose from 12 milligrams per milliliter to 50 milligrams per milliliter, a fourfold increase. And because nicotine salts are smooth, there's no aversive feedback. This dependence concentrates in rural areas. Daily use rose from 16% to 42%. Psychiatric comorbidities. 42% report moderate to severe anxiety/depression. And cannabis co-users, 60% vaping prevalence. This is population hardening. The casual users have dropped out. What remains is chronic high-dose dependence. Nicotine addiction is defined by three realities. First, receptor upregulation creates structural dependence where users require higher doses just to maintain normal signaling. Second, adolescent exposure causes permanent MGLUR2 downregulation and cardiac remodeling. Third, chemical engineering has systematically removed natural dose-limiting factors. The public conversation treats addiction as choice, as willpower, but when you upregulate receptors, when you remodel the prefrontal cortex during development, you are adapting to a pharmacological environment engineered to make dependence inevitable. Nicotine is not harmless outside of combustion, and for a growing number of people, the line between use and addiction was crossed before they realized it existed. If you're still here, thank you for being part of this journey. Subscribe to stay tuned for what's next.